So this is type 2 lumbar for the exam. Obviously your motion palpation. Okay? Sure. He has a very deep erector spinae, which makes it really difficult to get proper isolation. But for motion palpation, when you're dealing with types, the most important motion palpation is lateral flexion. Everything moves off that. Everything is based on lateral flexion. For the sake of the exam, you're going to be asked to do anterior flexion. Feel the space move up, cross up, yeah. Extension as well, okay? But the most important is going to be lateral flexion. This is the only area, thoracic or lumbar, where a normal is it's coming into you. Normally everything else moves away, but in this instance, you want the SP of the lumbar vertebrae to come into your thumb. If you feel it, if you feel pressure come off your thumb, then that's an indication that you have a lateral flexion fixation. Okay, so to be clear, if I'm putting in a lateral flexion and it moves into my thumb, then I have a type 1 or a type 3. Okay, to assess between the two and DDX between the two, when the patient is in lateral flexion, I'm going to challenge the SP. If it's a soft end feel, that's type 1, stays normal. Okay, if it's a hard end feel, then it's type 3, it's the intertransversae, and it's a disc issue. Okay, but because on the exam we're only dealing with type 2, we're going to have an abnormal value, so the SP is going to move away. Okay, and then I need to DDX between 2 or 4. So the way I DDX is I have my abnormal lateral flexion, and I'm going to put my patient into rotation. If I have a normal rotation, in other words, it moves away from me, then it remains a type 2. If I have an abnormal rotation and the SP moves into my thumb on rotation, then I have another abnormal finding, which is a type 4. Okay? But for the sake of the exam, we're doing type 2, so you just have lateral flexion abnormality and you have normal rotation. But a question that the TA may ask is, how do you DDX between the two? And the answer is rotation. And an abnormal rotation is type 4, and normal rotation maintains a type 2. Okay? So, and with type 2, it's called lesion side down, which means if I'm on the left side and I'm assessing lateral flexion and it's moving away from me, then the SP is kept to the right side, so that's a PR. So I would lie them down on their right side. Okay? So lie down on my right side. On your right side. You would want to go there. Okay? So in this case, the PR, the patient is right side down. Yeah, good point. Headrest comes up, helps with the patient. Okay? So my contact is going to be the mammillary process. The TVPs tend to go flat with lumbar vertebrae, so you have a mammillary process which can give you some leverage on maneuver. So you're coming off the spine, same as you would a TVP line up here. You're making a pisiform contact on the mammillary process, okay? And make sure your hand is parallel to the spine and not across, okay? So that's your contact. You want to make sure your patient has bottom leg straight, top one bent. Make sure if you feel like they're falling forward a little bit, get them to rotate their pelvis toward you a little bit. You can assess your contact. So a quick assessment is iliac crest. Follow it down. You've got your L1-L5 interspinous. Okay, so that's a good landmarking mechanism. And if you're up to, okay, and then you can move your patient's leg and feel the space open. And that's sort of what you want to feel, get them in that position. And then I'm going to make my contact, pull my patient's arm toward me. Okay, relax. And so that I'm keeping them stable on the table. Okay, because I'm type 2 and doing a roll, I'm going to go thigh to thigh. Okay, so I have my contact, okay, and I'm going to go thigh to thigh. And a lot of people feel that they have nowhere to go, so I always tell them to come up a little bit, okay, and make sure your arm is parallel to the floor and pushing straight through. Okay, so come up and then push. As Kellerstein has always done, you're pushing straight through and dropping with your hip as well. Okay, so that would be a roll. A hook, same setup generally. Fingers on the other side of the SP. You're hooking the SP back into position, the vertebrae back into position. So fingers reinforced, forearm contact on the trochanter. That's where you're getting your torque, knee to knee, and then thrusting. Both with the knee drop and with the torque into the arm. Okay?